Welcome back to the 2024 California Digital Health Summit, brought to you by the California Telehealth Resource Center. We are so glad you could join us for today's keynote session, Reinventing Primary Care After the Pandemic. I could not be more excited and delighted to have our keynote, and I'll introduce him in just a moment. As you know, this theme for the CTR Summit is sustainability and equity. Digital innovation makes it happen. I am Sylvia Trujillo. I am the CTRC Executive Director, and I will be your moderator today. So before we jump in, I have a couple of housekeeping items. First, this session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organizations related to commercial products or services discussed during this summit. Next slide. Here is a sort of quick tips around Cvent and Zoom. If you need any help, you can contact the staff, and they are able to assist you on the platform, or you can reach out to us at ochin.org. Please submit your questions in the chat, and we will have about 15 minutes left after Dr. Nundy's presentation for you to ask questions. And then I'd like to just acknowledge the funders for this event, HRSA within the U.S. Department of Health and Human Services, and within the state of California's HCI program. We appreciate their funding. I'd also like to acknowledge the sponsorship of the California Rural Health Association and the Digital Health Equity Ambassador Program. So with that, and not without any additional delay, I'd like to introduce you to Dr. Nundy. Many of you already know him. He is really nationally recognized for incredible work that he's done. I think most notably, he recently published a book, Care After COVID, What the Pandemic Revealed is Broken in Healthcare and How to Reinvent It. And certainly it has inspired a great deal of the work that the CalTRC does. And I would say that he's gone global, since he'll be addressing us from Geneva, where he is participating in a global health meeting, and is very apropos for the real vision that he brings. So he is, in his day job, the Chief Health Officer for Accolade, another organization dedicated to really promoting and enhancing the patient-provider relationship. And he also is a primary care physician at Neighborhood Health. So no, he does not sleep. So with that, I would like to hand it over to you, Dr. Nundy. There's much more I can say about the pivotal role that you've played in driving national healthcare policy, making global impact and changing the lives of individual patients. But I think you do that better than anyone else through the examples and stories that you share. So with that, it's handing it over to you.
Well, thank you so much, Sylvia. It's always wonderful to see you and collaborate with you. And yes, I'm actually, the reason I'm in this little box right now is because hotel rooms in Europe are quite small for anyone that had a chance to come to the other side of the pond. But yeah, actually, this week is the World Health Assembly. So every year, related to the World Health Organization, leaders from around the world get together. And, I think apropos for this whole conference that you guys are leading here is that the theme this year is all for health and health for all, which I think is, an acknowledgement that it's going to really require an all of society approach ultimately to improve health. And I think it's also an acknowledgement of sort of social determinants of health, and recognizing that we, as much as we love healthcare, that we only influence 20% of health outcomes. So absolutely delighted to have a chance to speak with you all today. And let me see if I can get my slides up here working for me. All right, I think that's working. Well, the title of my presentation is really a reflection of kind of, where we are, I think, in the cycle of the pandemic. Obviously, COVID is still with us. I actually had a patient with COVID just a couple weeks ago, my first in a little while. But we're certainly past, I think, the bulk of the COVID-19 crisis. And I think it's a really good moment to pause and reflect on what we learned. And I think most of us think about the negative things we learned, but there was a lot of positive as well. And so what I really want to convince you guys of in the next hour here is that, healthcare actually changed more on the ground in the past couple years of the pandemic than it has really in any year or two of its modern history. And that some of that change, I think, is change that all of us here have an opportunity to sustain and really continue to build off of. And so that's really what I'm so delighted to chat with you guys about today. And I'm going to start by actually, since COVID's still pretty fresh for us, to sort of invite us to kind of come into this space. I'm going to start with a story from some work I did a couple years ago when I was working at the World Bank. So when I was at the World Bank, I had an opportunity to work in Mozambique. And Mozambique, this is a picture actually of, this is my my plane touching down. And folks might remember, this was a few years ago now, but there was two very significant cyclones that hit Mozambique in a short period of time, displacing hundreds of thousands of people and disrupting the entire country. And as I'm touching down here, the ocean is supposed to be on the far side. That is the ocean. But on the close side to us, there's not supposed to be water there. And that gives you a sense of the level of devastation that the country faced. And so they had this, huge calamity for their country. And I was being sent by the World Bank to understand, how can we improve quality of care in that context? And I will tell you that I learned more about improving quality care from them that I could possibly hope to teach them. And so that's kind of why I'm using this as an illustrative example. This is Mozambique. So it's in Africa, the continent of Africa. It borders the ocean, the Indian Ocean, not as famous as its cousin across the way, Madagascar, thanks to Disney. But you can imagine that much of the country lives along the ocean. That's where a lot of the economic opportunity and social mobilization is. And so you can imagine that if very large cyclones hit this country, what kind of impact could it have, given that most of the population and most of the economic activity is concentrated, along the water. And so, when I landed there, they said, well, you should go out to the field. And in Mozambique, when they say you're going to go to the field, they really mean you're going to the field. And so, took, I think, a couple planes and got in a UN vehicle, along a highway, and then for about an hour on a dirt road. And this is us now getting out of the car. And this is the context in which healthcare happens for most people living in Mozambique, which is a very, very rural, very sort of village setting. And so when I got there, I said, wow, how could we possibly deliver healthcare here, given that, there's not enough people to really justify having a health center, let alone a hospital. And it turns out that their secret weapon are community health workers. And so this is Ashanti, who's one of their community health workers. The way community health workers work is that they're actually chosen by their community. So by the village elders, who we actually see on the corner there, they choose somebody that's most trusted by the community. They're very proud to wear these green jackets that designate that they are officially a community health worker. They receive training. Most of these are women, the vast majority, and the vast majority of them have not completed an 8th grade education. And they're really proud of the fact that they get a bike. And so they have a bicycle that they go around. But what's really remarkable, you can see it just a little bit in the photograph, is the backpack that she carries with her. And so in that backpack is actually, in some respects, more technology, more tools than I have in the clinic that I work in every week outside of DC. And that, she has a thermometer, she has a pulse oximeter, but she also has rapid diagnostic tests for malaria. She also has medications. So she's kind of a pharmacy, laboratory center, and clinic all in one. And really importantly, she has a mobile phone. So this is a photograph of one of her colleagues using the mobile phone. And so they use the phone, given the level of education that and training that they have, to actually make diagnoses. And so the phone will tell them every step of the way what to ask. In this case, a mother of a child under 5. And what's really important about that is, as they're using the system, so again, they're not just documenting after the fact, the system's actually helping them provide evidence-based care. The system's documenting what they're doing. And so what that allows them to do, because stockouts are common, they run out of medications or run out of diagnostics, is they can see in real time what their supply is. So you can see in this image on the right, paracetamol, which is what most of the world calls Tylenol, is running low. And so that means that when there are supply chain issues, which you can remember from the pandemic, there's an analogy there, they're able to respond to that, in the field and make different diagnostic and treatment decisions based on what's available. They also use a lot of data. And so there is a local health center. That's where, births are done. And they have data that tells her how she's doing on a population level. Now, in the US, if you come to a clinic and you say, who's your population? We'll typically say, well, it's the patients that come here. But when you're doing real public health and community-based care, your population, when I asked her to tell me the population, she picked up a stick, and in the sand, she actually drew a picture of her community, and she showed me, here are all the households that I have. In fact, if you ask most community health workers, they'll actually tell you, I'm responsible for 117 households, or I'm responsible for 123 households. And so when they're looking at data, it's not just on a bias sample of people who happen to come to clinic and happen to get care. It's actually the entire, real sort of population based on a geographic unit, and they're able to see their results. And so what this is showing here is what percentage of women in a given month receive their 4 or more prenatal visits, and what percentage of women actually deliver in a health center, which is one of their very significant quality measures that they have. So she knows her population. She has data on them, and she sees that data as part of her workflow when she comes into the setting. So I use that as a sort of opening example because I think it's fun to kind of think about a different world when we think about healthcare, but also to point out some of the key pieces, right? This was a health worker who was incredibly empowered with tools, technology. She had access to data. She was delivering care, truly meeting patients where they were, so in their own homes, right? And what that allowed is that even though there was this catastrophic cyclone, it turns out that it's like that old adage, right? If you have all your eggs in one basket and the basket breaks, the eggs break. But here, even if the hospital's flooded, even if a couple homes are flooded, because she's delivering care in so many different places, it doesn't disrupt the actual healthcare system. And so again, there's some foreshadowing there of what we'll talk about. So with that, I sort of want to, again, sort of talk about, now that we're largely out of it, COVID-19, what did we learn? What changes happened? And sort of what I think this means about where we need to go next. So in terms of what COVID taught us, I think this was a tweet that an infectious disease doctor in Boston sent out fairly early in the pandemic that, sometimes I almost strikes me that this was just a couple years ago. It's how quickly we've sort of moved on, but hopefully this message sort of grounds us in the reality of that we were all dealing with at that time. And for folks who don't know this place, this is the Billie Jean King Center. This is a part of the US Open, one of the grounds for the US Open. And it was very important during the pandemic because, right at a time when New York was surging and they were running out of hospital capacity, New York made a Herculean effort, a truly Herculean effort to set up the Billie Jean King Center as a makeshift hospital. So this is incredibly impressive, right? The mayor puts out a call for proposals. We want to build a hospital, and they literally had to submit proposals within a week. And, less than a month later, an entire hospital opened. I mean, just think about that. Really incredible effort. But the result of it was less spectacular, right? So just a month later, even though New York was hit so hard during this time, the hospital ended up not treating very many patients. And so it's an interesting case study for us to ask ourselves, well, when we're talking about change in healthcare, what really matters? It's not just about building something. There's more to it that makes it all possible. And in the case of this, the hospital that they set up, there was really a bunch of different issues that I think are cross-cutting across all the work that we're trying to do here together, right? So trust was a huge issue. right? You're saying that this is a new hospital, but people want to know, is it going to have the same quality of care? Is this the right place for me to send my patients or for me to send my own family? There was communication issues where doctors were being told that they couldn't transfer patients to that hospital, even though they actually could. There's coordination issues. You can't just think about yourself as a single actor. You have to coordinate. So you could build the hospital, you could be excited about it, but if the ambulance system isn't aware, and then secondly, have incentives to be able to put people in the right places, that can be an issue. And certainly the payment model of healthcare was an issue in this case because some hospitals didn't want to lose the patient volume that they had. And there's also policy artifacts. When we don't have clinicians at the forefront of policy, interesting things happen. So in this case, one of the exclusion criteria was people that had a fever. And the whole point of setting up a COVID hospital, as you might imagine, is to take care of people with fevers. And so these are the disconnects that ultimately led to the situation here, and I think that are pervasive, when we try to bring about change in healthcare. And you can imagine the impact this could have had, right? If you remember scenes of New York during that time, Central Park, people being transferred there, or just not enough beds and people crowded in the emergency room. Here we had a hospital that we weren't actually using. What else did we learn? Well, one of the things that we saw really early on, for those of us that remember those first few months, was that hospitalizations dropped. And that's kind of an interesting phenomenon, right? You think, well, this is a pandemic. If anything, there should be more people going to the hospital. And certainly for things like on the right, cardiovascular disease, why should a pandemic affect hospitalizations for cardiovascular disease? Well, the reason is it goes back to my egg carton analogy, right? Because the hospital was overrun with COVID, because the only place to hospitalize people is in a hospital, when the basket gets overrun, or in the case of Mozambique flooded, the entire system comes down. And we saw that exact same phenomena happen when it comes to primary care. Clinic in the United States, or primary care in the United States today, happens almost exclusively in a clinic. And so when people are scared to go to the clinic because they don't want to get sick in the waiting room, when they have stay-at-home orders, etc., because we've coupled primary care and clinic-based care so tightly, it means that when these events happen, that care decreases. And so a couple of colleagues of mine wrote a paper. We called it the second hit of COVID-19, where we actually anticipated that this would happen. And we sort of were trying to rally the community around this notion that just as many people are going to be impacted by COVID as they are by the secondary effects of COVID on the healthcare system. And unfortunately, those words weren't heeded. And so we've seen tremendous decreases across the board that we're still digging ourselves out of. I certainly still see it in my patients today, that people miss their cancer screenings or have stopped coming to primary care and they just haven't come back, unbelievably. And so the impact of these things can actually last for an entire generation. And certainly that's the case when it comes to mental health, as I think many of us are very, very aware of. A huge, headline that we saw throughout this was that really was a magnifying glass when it came to health disparities, right? We've had health disparities for a long time. I remember very early on, people were talking about how celebrities were getting it and how the COVID would be the great equalizer. And, we all know now that it was absolutely the opposite of that. People that were marginalized were more likely to get it, more likely not to get care from it, and more likely to have significant complications of it. And it certainly, wasn't something new for those of us that have been working in this space. All are very, very aware of. I mentioned the mental health part as well, but it's just the numbers are just absolutely staggering in terms of the impact that it had on mental health. And it just showed also how woefully unprepared we are around the supply side of mental health, and particularly access to therapy. And so, as I mentioned, it was really overarching a magnifying glass, right? We over rely on physicians, right? Remember that time when, in order to get a COVID test, you had to have an order from your doctor before we opened up at-home testing? That meant that if you don't have access to a doctor, you didn't have access to a COVID test. Later, that was true again when we had treatments for COVID. The only people that got access to the medication were people that had access to a doctor. So again, when you tightly couple those things, it makes sense in some ways. As a physician, I understand that, but the reality is when 20 to 30% of Americans don't have a physician, by tightly coupling that means that if you don't have a doctor, you're not actually going to get care. And that was something I think that was highlighted. The clinic part I talked about, the hospital part I talked about as well. And then certainly across the board, just lack of access to testing, the mental health care piece that I talked about, systems. I remember between a couple of the peaks of the waves that we had in Virginia, that one day I showed up to clinic, and I remember this so well. My clinic schedule was almost empty. And I remember, hitting refresh on my eClinicalWorks, wondering if there was a bug. But what happened was, COVID had been controlled in our area. But at the same time, people weren't yet coming back for routine care. And so I just picked up the phone and I started calling my patients with diabetes or calling my patients with hypertension and saying, hey, I'm here. How can I help? And of course, patient after patient needed a refill, needed blood work, had a question about their treatment. Because we don't have systems. We wait, by and large, we wait for people to come to us and raise their hand and say, I need help. We don't have systems to making sure that the people that need help, we're actually proactively helping ourselves. And certainly there's a ton of underpinning, right? The systemic racism that I think is pervasive across society, and certainly within healthcare. Mistrust was a huge underpinning of what we saw. And then certainly the lack of public health systems, and really the importance of public health, I think, became really starkly magnified for all of us. So I promised that it all wouldn't be negative, and so there were some really positive things, and I think it's really important that we remember these pieces too, right? And so I think the one that most of us that are clinicians will remember is how care became virtualized. We'd been talking about telehealth and telemedicine and for decades now. In fact, I read an anecdote that that the first phone call ever made was a telemedicine call, because it was when Alexander Graham Bell was calling his colleague. He accidentally dropped some battery acid on himself, and the first conversation was what to do to get the acid off of him. So we've been talking about telehealth for a long time, and in my clinic as well. And yet, here we were at the beginning of the pandemic. In less than 2 weeks, my clinic went from 0 to 80% virtual, which is just absolutely astounding, and a testament to I think so much of the work and that we did on the front lines. The second picture is of a drive-through testing site, right? This is a photograph of actually that patient that I'm talking to on the phone. I said, why don't you come in for testing? And we set up a testing site, just taking a picture of it through the window of my parking lot. Care also shifted into the home. People were scared to go for care, as I mentioned earlier. There were stay-at-home orders. And so we saw a really significant proliferation of primary care, almost going back to the days of Marcus Welby, and not just for older Americans. We saw many Americans access care at home, and certainly telemedicine from home as well. We also saw, this was less talked about, the shift of higher acuity care, almost ER level care at home. So there were companies and organizations that basically said, hey, what is an ER? An ER oftentimes is some oxygen support, a breathing mask, a chest x-ray. We can do that at home. And so that also got scaled up very significantly during the pandemic, some of which has sustained itself as we've come out of the pandemic as well. And so again, this idea of meeting people where they are in a place that they trust, I think were really positive signs. Not everything moved as fast as we wanted to, so going back to when New York was hit and other cities were hit, some colleagues of mine, basically, tried to sound the alarm and say, hey guys, this is the right moment to accelerate hospital at home. It's been around for 30 plus years, multiple randomized studies, a Cochrane review showing that it's safer, more effective, patient-centered, lower cost. But unfortunately, we just didn't move fast enough. And so hence we were trying to put people in a tennis stadium, something unproven, when there was something proven that we could have scaled up during this time. And we really haven't. We got some waivers passed, but it really hasn't happened to the degree that that really the data shows that it should be. One of the other really positive things that I think hasn't been talked about is how people got involved, patients, right? If you remember people posting on social media or Facebook, hey, I just got this bill for $2,000. Isn't COVID test supposed to be free? It really galvanized the community to say, well, that's not right. That shouldn't be the case. And bills got taken down. I think I also saw, patients got so much smarter about healthcare, right? They would come and ask me about the sensitivity and specificity of the test that I was going to use. They talked about the efficacy of the vaccine and the Omicron variant, right? I just think the general public, most of us are healthy and don't really access the health system, but all of us, I think, had this sort of shared visceral experience of trying to get the vaccine, trying to get care for our loved ones, care for our neighbors. And I think that's generated this sense of like, wow, this system really, really isn't what we want it to be. So things that I think physicians and nurses have been saying for years, we're seeing the like patients seeing it. And that I think is an incredibly powerful force for change. And so the other one is the focus on health equity. You know, part of my jobs is I get a chance to work with employers around the country, and I started seeing employers that said, listen, we're not going to implement any solutions that don't take health equity into account. And as someone that did a fellowship in health disparities many years ago and has always worked in marginalized communities, that was so welcome to see. And so a few colleagues of mine and I sort of institutionalized that. You know, we all know about the triple aim, right? About 10 years ago, we added the quadruple aim, recognizing that you can't just get better health, better care, and lower costs. You have to do it sustainably, meaning that you have to take into account health worker well-being and burnout. We said that we got to extend it to the fifth aim, which is it also has to advance health equity. And so this was a piece that we published in JAMA, and it's been fun to see more and more organizations that used to point to the triple aim or used to point to the quadruple aim now pointing to the quintuple aim. And it's a meaningful shift. You know, the example I always think about is, you know, every couple of years, my clinic will say, we're going to improve colon cancer screening, right? And so what do? We train the MAs, we do some workflow, we do a little widget in our electronic health record, all of which is really good stuff. But guess what that means? If all the intention and effort is going on to the waiting room or to the exam room, that means it's only helping people that are coming to clinic. And the moment you do that, you've taken 30% of the population, 40% of the population, and you've actually worsened the disparity, because you'll see rates of colon cancer increase for people that are accessing the clinic. But guess what? The people who aren't accessing the clinic, who are the most marginalized, we're not seeing that improvement. And so that's an example of where, by thinking about health equity from the start, instead of only focusing on what's happening in the exam room and in the waiting room, you might actually, you know, partner with the church down the street like we did during COVID to get people vaccinated, or you might have a more community-based outreach effort where you're either knocking on doors or calling up homes of people in your community and saying, hey, let's get you screened for colon cancer. And so we've been really, you know, it's been really a positive to see the uptake of this, and I think starting to change the way that people are thinking about improvement and innovation. So at this point, I mean, there's all this good change that happened, but I think a skepticism that I get very reasonably is people said, yeah, but we were doing virtual care, now we went back, and oh, the HIPAA regulations have gone back and things have changed. And it's true, we've had a lot of reversion, including of things that I think were really positive. And I still think that the ground is really ripe for more change, because I think culture has shifted, mindsets have shifted, right? I mean, I think before the pandemic, if you ask most physicians, they'd say virtual care is lower quality, or home-based care is lower quality. And I think patients would say the same thing. But now that we were all forced, sort of necessity being the mother of invention, to do virtual care, do home care, I think that we have a much different view. We trust care in those environments a lot more. We've all heard that medicine moves at the speed of trust. And so that part, I think, isn't going to change that experience. And I think for folks like myself, I think that, for example, for mental health, it's actually better than care in a clinic for a variety of reasons. And so I think that mindset shift will not reverse as fast as some of the policy and utilization things have shifted. As I talk to health systems around the country, you know, they saw their revenues drop precipitously, because when you operate like a hair cuttery or like an ice cream store, and people aren't, you know, going to the ice cream store, they're also not coming to the hospital. And so I'm seeing more interest in value-based care because of the impact that they saw. I also see a lot more optimism that, you know, people think, oh, the front line, they don't like technology, they don't really move, they don't really change. But the fact that we adopted virtual so fast, and many other things, I think has created this sense of like, oh, actually, you know, health care professionals are really innovative and creative. Maybe we were just pushing some of the wrong things. And so there is that muscle that we have. Similarly, I see big shifts in the way policymakers view this. And I already mentioned the shift that I think employers have as well, given that they buy healthcare for half of Americans. their perspectives have shifted as well. And so I think these changes will sustain themselves even as policy may or may not shift. So we recognize that, COVID, I think, was a singular experience that got the entire country to recognize the shortcomings of healthcare. We saw the beginnings of a new healthcare system, and we saw critically the cultural shift. The question now is, okay, well, where are we trying to shift to? What do we have to get to? And so, uh, I always just think about simple anecdotes. And so, my mom, she's had type 2 diabetes for almost 30 years now. And for almost all 30 years, her diabetes wasn't controlled, which as a doctor's son is, the most infuriating, challenging sort of situation to be in. But at the start of the pandemic, if you remember, people were talking about how if you have obesity, your rate of complication is higher. If you have diabetes, your rate of complication is higher. She finally said enough is enough. And so early in the pandemic, I think it was June of 2020, my mom signed up for a service that has really completely changed her life. So she, signed up for this service called Diabetes Reversal that's delivered virtually. She was provided a home testing wireless kit for her glucose, but also for her ketones. So she's got a wireless ketone monitor. She was given a mobile app and access to a 24/7 health coach and nutritionist. She got a physician that was available to her also virtually, that she really got to know very well. And then really critical for my mom, my family's from India. My mom is vegetarian. The program actually connected her with a peer, somebody who was a few years ahead of her in the program, who she was able to swap recipes because she ended up going on a ketogenic diet, which is pretty challenging to follow when you're a vegetarian, let alone a vegetarian who prefers Indian food. But anyways, this suite of sort of this entirely different care model, the result of it was within a week, my mom went from 40 units of insulin down to 20. Within 2 more weeks, she got completely off of insulin, and it's now been over 3 years, maybe 4 years at this point. And my mom still is completely off of insulin. Her diabetes is reversed. She also lost like 25 pounds, and that's a picture of my mom, who I think is really living her best life after those changes. And so when I think about where healthcare needs to go, I just think about my mom and think about, well, what we didn't do was simply take her, okay, I'm going to see the endocrinologist for my diabetes every 6 months or every year, and hey, let me go do that online. We didn't just do that, right? What she really got was a completely different care model where we said, oh, now that care is virtualized, how could we do it differently? Right? How could we, instead of connecting her to the doctor down the street, how do we connect her to a doctor who is an expert in diabetes reversal, which she may or may not have in her community? Now that care is virtual, how can we bring in other types of health professionals like nutritionists into it? How can we bring wireless technology so that the team was able to follow her blood sugars and her ketones and call her on the 3rd day and say, Anju, I think your sugar's too low. We need to bring down your insulin faster, right? How do we use this moment to say, let's not just do the same, but virtually, or let's do the same, but at home, but actually really reimagine what healthcare can do? And that's an overwhelming proposition on some level to think about. And so I created a really simple framework that some people have called the 3Ds, which is that healthcare needs to become distributed, digitally enabled, and decentralized. And so what do we mean by that? Well, distributed, this idea is that care should happen where health happens, right? And when we talk about chronic conditions, you talk about prevention, those things happen at home, in the community, online, right? It happens in schools, happens online. I prefer it to just saying digital or virtual because, hey, not all of us are digital and virtual, as we all know. When we talk about the digital divide, it might make more sense for it to be a barbershop. It might make more sense to be a school or to be a senior center. So regardless of where people are, the principle is meet them where they are, which is why I don't like only talking about home care or virtual care. Let's talk about distributed care. The second is this idea that care should be digitally enabled. And so when I'm really talking about digital enablement, I'm really saying that technology can strengthen relationships, right? It's like, what I love spending time with my wife. I'll also text my wife. When I text my wife, it doesn't mean I'm trying to replace my interactions with her. I'm actually augmenting it, right? We have a relationship in the real world, and we're using asynchronous communication to be able to extend our relationship during the day so that we can stay on top of what's happening to our 2 daughters, right? So that is the idea behind digital enablement. And it's on, multiple fronts. It's the relationship between the patient and the doctor. It's the relationship between the doctor and specialists that they may work with, or the care team that they work with. It could be the patient and their caregivers. So there's a lot of different relationships that we all know have to be brought to bear. And I think there's a real role for technology and data to again help strengthen those relationships. I had a patient once tell me, Dr. Nundy, the worst question that any doctor ever asks is, what brings you in today? And I said, what's so bad about that question? She's like, well, I've already answered that when I called and made the appointment and told the front desk person. Then I had to answer it again when I checked in. I had to answer it again in the waiting room. I had to answer it again when I talked to your medical assistant. And now you're asking me for the 5th or 6th time, right? So those are the opportunities we have around data and technology, but it's all towards this eye of how do you, bring more care into healthcare. And then finally, decentralized, I think, is the most sort of abstract, but it's the idea of we got to bring resources closer to people, whether that's the patient or the doctor. So one example that always stays with me is, this was a few years ago. I had a patient who, wonderful, sweet, older lady who was in and out of the hospital with heart failure, and I saw her after one of the hospitalizations, like her post-discharge visit. And I must have gotten up on the right side of the bed, because at the end of my spiel about eating the right foods and watching herself and weighing herself, I asked her, I said, Miss G, do you have a weighing scale? And she looks at the ground and she says, no, I don't. I can't afford one. And so, immediately my heart sank, right? Because this is a woman who had been in the hospital multiple times just in the past year. I had seen so many times, and everyone probably told her to check her weight. None of us, including me, asked her, did she have a weighing scale? And so, I ran around my clinic seeing if we had any free weighing scales that we could give her, and we didn't. And I ended up just handing her $20 out of my wallet. She bought a weighing scale, and she didn't get hospitalized again that next year when I was caring for her. And so that's what I mean by decentralized, is people are talking about value-based care, but value-based care is great. One of the challenges is that you have a bunch of resources that sit in an insurance company that now sit in the administrative side of a health system or a clinic. What's not happening is those resources is being pushed to the front line, right? So what's not happening is those resources aren't being pushed to me so that I could get her the $20 weighing scale. I could get her probably a $5,000 cardiac catheterization, or I could get her a $3,000 exercise stress test, but those resources aren't being pushed to the front line. The same thing happened with my mom, right? I mean, her being off insulin is saving the healthcare system tons of money, but she had to pay out of pocket for that service. Nobody's coming to her and saying, Anju, you can either see an endocrinologist 4 times this year, or we're just going to hand you money so that you can go sign up for a diabetes reversal service, right? That's the example of decentralizing resources. Give it to families, give it to doctors. They're the people that know what the resources is needed for. Let them get more stewardship of those resources so that ultimately we can decide for each given family what it is that they need to unlock their health. And there's so many examples of that. So I was just bringing in an example that was, that we saw during the pandemic, was there was so much debate about what to do with the antiviral COVID medications. And there was a lot of debate as to, whether we should allow pharmacists to give it. But to me, part of decentralization is you want to give as much as you can safely, empower people closer to care, right? We saw the same thing happen with the whole birth control pill, which fortunately now has been approved for, as you guys know, for patients to get over the counter. Those are the types of things we need more of so that we don't bottleneck care on access to physicians, and really be able to drive public health access that way. So where is all this sort of going? So we have the 3D framework, but just to kind of give a few analogies to sort of contextualize it, right? So if you remember that thing on the left, that's a bank, right? So we used to go to banks for all of our banking. Now we have, then we had the ability to use an ATM. And I still remember my first experience when I actually deposited a check on my phone and thinking, oh my gosh, I should save this check. What if I don't get my money, right? So I think that, it doesn't mean we don't have banks anymore. We still do. It doesn't mean we don't have ATMs. We do. It just means that we are distributing more care into the home, right? In this case, more access to banking from home, so that when needing the ATM or needing the bank becomes more the exception and less the rule when you're trying to get simple things done, right? So like we live in an environment where 20 to 30% of patients with HIV don't know they have HIV. And that number, by the way, hasn't really changed in a couple decades. We need to start giving people access to diagnostics themselves, like we did with the COVID-19 home testing kits, so that people can access that information and that those diagnostic support where they are, because that's going to dramatically expand access. And so there's so many more examples to that concept. One of the risks as care becomes more distributed is that it becomes more fragmented. And so it's also really critical that care be more connected. It has to go from a nice to have to a need to have, that as people are, maybe taking a home test at home, but getting their primary care in a clinic, but having their specialist virtual, these systems have to talk to each other. And that's one of the really big frustrations right now, that care is becoming more fragmented, but there's a way that we can use data to do that. And in my role at Accolade, that's a huge part of what we do. We have a lot of different partners, like the ones you see on the page, but we require that our partners share data with us, and so that we're able to follow patients. So they're getting the best possible services, that are right for them in the way that's right, in the way that's convenient for them, but at the same time, that longitudinal relationship can be intact. Care also has to be more continuous. So this is that example of diabetes reversal, which is, when we started doing virtual care or home care or whatever you want to call it, all we did was we made it more convenient. But really then what we started to do, as you're seeing with, remote monitoring, is then we said, okay, well, let's start monitoring people 24/7. The next transformation is like my mom's example, where we actually need to now, get to root causes and start shifting behaviors and shifting structural environments so that we're getting to a reversal. There's no way we're going to deal with the onslaught of obesity and type 2 diabetes and other things if all we're doing is treating. We have to start using the data and the technology to be able to drive a completely different set of outcomes. Clinic practice will change. We all know the statistic that it takes 17 years for a standard new evidence-based practice to be mainstream. But we saw during COVID that I remember my clinics, sometimes our protocols would change weekly, right? Like first the vaccine, we only had it for people over 70, then it was over 60, people with 3 chronic conditions too, right? The pace of change that we had to have, I think is something that, technology can enable as we get decision support and as we build much more collaboration within teams. Which is another area, that I think that is desperately needed. We all learn in medical school kind of on the left, we'd go through the wards with huge teams of people. You'd constantly be learning from each other. And this is me on the right in clinic, right, where I'm largely a solo practitioner. And so I think that need for care to be collaborative, I think it's a huge part of, the sort of the culture of medicine, but it's being lost. And I think that, again, there's a lot of opportunity for us to shift that, like you're seeing with like tumor boards or other types of constructs that I think bring a lot more collaboration and expertise and socialization to the work we do. So as I wrap here, and I really look forward to getting into the questions and comments as well, maybe I'll just end with sort of 3 just sort of things that I've learned along the way as I've been sort of guiding other folks around this work. The first is to actively include, right? That it has to be an active verb, that we think day one about the individuals that are the most marginalized in the way that we design care. And what I've learned is that when you do that, when you design for the margins, you typically get the median, but if you design for the median, you don't get the margins. And so to me, it's not a binary question. People say, oh, but we can't do digital health because there's a divide. I don't think it's like that. To me, it's more like, how do we design the way that we're doing digital so that we can make sure that it's inclusive? And we've seen so many examples of where that's happened very effectively.
Great.
The second one is really this idea of integrating care, right? That we can't look at every part of the care experience independently. We really have to think about the patient experience. So one of the experiences I remember having during the pandemic is my daughter, who now has asthma, was first getting her first bout of asthma on a Saturday night. She was having trouble breathing. I called her clinic and it said, hey, this is the after hour service. Leave a voicemail for $25 and we'll get back to you. And I remember thinking, oh my goodness, right? When are they going to get back to me? She's having trouble breathing. Well, it turned out they were going to get back to me in a minute or two. But the experience, the way we designed it for how the patient sees it, the patient didn't hear that. The patient just heard for 25 bucks, leave a voicemail and we'll get back to you. It didn't say leave 25 bucks for a voicemail and we'll get back to you within X minutes. Like it's those types of things. It's thinking about that end-to-end experience that I think really makes the difference when we invest so much in systems, but we don't think about the patient or caregiver experience through that. And so really, they see healthcare as one thing. They don't see it as each individual silo. And so we have to design for that. And then the last recommendation I have before I transition, we get to questions, is really this idea of reinvention. And I've hit on this, I think, multiple times, that we can't just do the same, but virtually or at home, or can't do the same, but then now we have the data be integrated, right? I think we have to say, now that data is integrated, what can we do differently, right? So an example is, we're going to get a data feed from a specialist. How do we use that to trigger an automatic outreach to the patient, right? How do we do things differently with the data we have, and not just use the data to sort of fill in what's already a broken system? And so there's so many examples of that I think we need to be doing more of. So I'll kind of end us on this note, which is, I think all of us have gone through this incredibly challenging time with the pandemic, and certainly now we have other challenges that we're also dealing with. But when I think back around, the analogy of sort of World War II, and we had this obviously global calamity that at the end of it led to things like coming back full circle, the World Health Organization and the World Bank and the United Nations, right? Those are so many philanthropies, so much community building, all came out of people that came back from the war and said, we have to do things differently. I think that that's the moment we have in front of us, right? That we've, I think, all understood and magnified the challenges we have. We started to sow the seeds of change. And now I think we have this really once in a generation opportunity to rebuild medicine and healthcare the way that we know it should be, by putting patients and communities first. And so I really think we have this opportunity to be medicine's greatest generation. And so just really grateful for the chance to chat with you all today, and looking forward to the conversation. So thank you so much.
Thank you, Dr. Nundy. So we do have a couple of questions, and then a little bit of a conversation. So one of the first questions we have is, in your opinion, how can we encourage our care team and providers to engage with change as opposed to reverting to pre-COVID tendencies? For example, engaging with telehealth and patient portals, from Jorge Garcia.
Yeah, I mean, Jorge, that's a really, really great question. I think one of the things I've learned is really starting with why, right? And I think when I start with why, I find that the further back I start, or the bigger picture I start with why, the better off I am, right? So you could say, well, we got to use the patient portal because we got to get back to patients. That's sort of a why, but it's sort of a circular why. Like what I find is really having those sort of co-created visioning exercises that says, why, like, what is the kind of care that we want to be providing over time? Like, how do we see the experience for families? How do we see the experience for ourselves? Really starting with that, then creating a common language around it, so that when then 2 years later you're saying, oh, we got to increase this or decrease this, or we have to use this new thing or that thing, recalling those words and recalling that framework, I think have people, like, they kind of check their guns at the door and they say, oh yeah, I remember that this is what we're trying to do, and that's why we're trying to do this, right? It gives people a construct within which to keep up with the incredible amount of change that sometimes we do, ask of our frontline care teams.
Another question is, how do you think the process would work for integrating large-scale digital health on a global scale, for example, in communities such as the one you mentioned in the beginning of the presentation?
Yeah, well, that's a great question, and one that I've gone to a bunch of talks actually on, that I learned from earlier today. I mean, I think that I think part of what I've learned is, in global health as well as U.S. healthcare, I think we started first with applications, right? We started with like, oh, there's a telemedicine thing, or there's a, at-home testing thing, or there's a coaching thing, right? So we had a proliferation of sort of applications. And I think then what that led to was this incredible, amount of confusion and issues with privacy, issues with, interoperability, issues with adoption. And I think that what the global health community is doing is really, they've done a sort of a sidestep, maybe not a step back, and saying, wow, we need to have the right frameworks in place. And I mean, Sylvia's really the expert on this, but the frameworks in place so that we can have that, what we call harmonization, right? I think part of the 3D framework is people always ask me like, oh, should we do telemedicine? Should we do this? Should we do this? And I'm like, that I think healthcare is local and it should be local. So I'm purposely giving a very broad framework, and policymakers need to give a broad framework so that individual communities, individual, doctors and patients can decide then what applications can sit on top of that framework. I think that's really how we're going to be able to do this at large scale. It's not about being prescriptive, but it's also not about the wild, wild west. It's about creating constructs that allow people that agency to design for themselves and their communities, what's really ultimately needed to improve health.
So, Dr. Nundy, I think one of the challenges, and they're actually threaded through these two questions, that even our resource centers are facing in terms of making the case that digital health can answer those local pain points and gaps in care, is that we have in the state of California post-COVID, the percentage of operational staff in community health clinics was devastated. There was like a 30% loss of operational staff. We have, as you know, record-breaking clinician burnout with the highest percentage of clinicians indicating that they will be exiting the profession in the next 2 to 5 years at a much higher and accelerated rate than we've seen historically. And then we have a confluence of long COVID, the opioid use disorder epidemic, and the mental health crisis. So there's a lot that's ailing the country, and we're focused on, for this conference, sustainability and equity, and arguably the providers that would stand and the patients that would stand to benefit the most from new digital health modalities have the very least resources in terms of staffing and just capacity to do that sort of thoughtful process you outlined of like, what do we need? What do we want to achieve? And then how do we get there, which may or may not include digital modalities, but they can't even get to that point. So we can help them provide some tools to help frame that. But from a policy perspective and thinking about what could be done in these global conversations and these national conversations that you're part of, how can we drive the value proposition of transforming the safety net first, as opposed to the academic flagships that many are now pouring into for healthcare AI, for example?
Yeah. 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 I mean, I think you're asking, I mean, Sylvia, I think one of the most critical questions of our time, right? Which is that, I think it even ties to Jorge's question on some level, which is, we're asking people to change, and even good change is change, right? And change is always hard. And I think when you really ground yourself in the burnout issue, I think it's a really, really existential question as to how can we drive change given that people are so burnt out. And I think it's probably the biggest headwind that we're facing. One of the areas that I'm particularly excited about is sort of, I always think about patients first, right? And I always think things that we do to help ourselves, I always think like we got to help the patients first. And I'm the first to be optimistic to say that when you help patients first, like when we had some of our doctors work at the church down the street to get people the vaccine, or when we do home visits, I really feel energized and I get reconnected to purpose, right? But despite all those things, those comments, I think we really have to kind of turn, sort of put the fire out. And so what I'm now talking to people about more is to say, what are like really 10x, very dramatic things we can do to first give doctors their oxygen mask and nurses their oxygen mask. And then we can talk about change that we need to bring about for patients. And I think the one area, I mean, always talking to your staff, I think is the most important thing. But one of the areas that I think is just absolutely transformative is the AI scribes. Again, not to pick a narrow solution, but I've been involved now with multiple organizations that have gone from, so just for everybody's benefit, just like some clinics, as we all know, have scribes that sort of like med students or others that kind of do all the documentation for us. Now AI has gotten so good that you can actually have AI do the documentation for you. And again, it's not going to be for all clinics, but I will tell you that the clinics that I've seen and the individual doctors, like you literally see the lights go back on in their eyeballs. And I think that that's the kind of thing that, so now going to the policy perspective, what did it take for us to adopt electronic health records, which arguably we did not love? All right, it took a very large policy initiative and a large amount of funding to really make it happen. I don't think it will take as much, but it will take funding. And I think that I see us not moving fast enough to ensure, to your point, that the safety net gets access first or early. What I'm seeing instead is that the private sectors are taking it on right now fast, to the point where I'm worried that if we, the safety net, don't start implementing these technologies in 3 to 5 years, it's going to be really hard for us to recruit doctors. And we're going to lose even more of them because people are saying, I don't want to work at a place where I got to touch a keypad because all the other clinics in this area, I don't have to touch my computer. I mean, the technology is that good. And so I think right now it's an opportunity, and pretty soon it's going to be a threat for us to really give some relief to these frontline providers.
Well, you're always brilliant. You're always inspirational, and we're deeply indebted, not just for the time that you've spent with us today, when you had the opportunity to just spend it with global leaders. And that is what's so great about you, Dr. Nundy, is that you do always bring it back to local communities and doing, I think, the good work both at the higher level and within the community. So we thank you for your time, and we look forward to seeing you again and collaborating with you in the near future, and safe travels back.
Thank you so much. This is such an important conversation, and always happy to support. So nice to see you all.
Thank you.
All right. Bye.